Good evening, everyone. At the outset, I would like to thank Endocrine Society of India for giving me this opportunity. Thank you, Unni sir, for the kind introduction, and Jay Kumar sir for setting the tone for this talk. And I'd like to begin with congratulating Dr. Shweta for an excellent talk. The topic of my talk is anti-cancer drug-induced thyroid dysfunction. Why we should worry about thyroid dysfunction in a cancer patient, and what are the possible mechanisms for thyroid dysfunction in a cancer patient. Although this talk is focused on anti-cancer drug-induced thyroid dysfunction, we should not forget that even radiation to CNS or radiation to thyroid gland is not uncommon in patients with cancer, and this could lead to thyroid dysfunction. And frequent use of iodinated contrast is not uncommon, and this could independently lead to hyper or hypothyroidism. Why is recognition of anti-cancer drug-induced thyroid dysfunction important? This is important because in lieu of so many symptoms that a cancer patient present, it is very, very likely that you would miss out on symptoms of hypothyroidism or hyperthyroidism unless you actively look for them. Presence of hypo or hyperthyroidism may affect clearance of several anti-cancer drugs, and this may have an implication on the efficacy of the drug or the side effects that may emerge out of the drug. Undoubtedly, the quality of life of cancer patients is affected by the cancer itself, but if hypothyroidism or hyperthyroidism is untreated, it may additionally affect their quality of life. And obviously, there is risk for life-threatening events such as thyroid storm and myxedema coma if these are left untreated. So these are the reasons why we should talk about this topic. There is one important and interesting aspect of thyroid dysfunction that has been seen with anti-cancer drugs, and that is improved therapy response in terms of primary disease. That is, we are talking about cancer. And it has been seen that those patients who develop thyroid dysfunction following anti-cancer therapy, they portend better or favorable therapeutic outcome in terms of cancer treatment. And this can be attributed to two major causes. The first and most important is the bias, because those patients who are developing thyroid dysfunction or endocrine adverse effects, they are more likely to have received the drug for a longer period of time, and so are more likely to also respond to the treatment. And second and most important, that is with cancer immunotherapy, if you develop endocrine adverse event, that does mean that your immune system is getting activated far more better, and it is far more effective in destroying the tumor cells. So these are two major mechanisms or postulates why thyroid dysfunction is associated with improved therapeutic response in terms of anti-cancer treatment. And it is now known that screening for thyroid dysfunction in patients who are receiving anti-cancer drug is beneficial. However, unfortunately, there are no official screening recommendations for anti-cancer drug-induced thyroid dysfunction. And so much of my talk will be based on review articles, and these are two good reviews. And the first one was published in year 2011, and the second one was published recently. Dr. Bhattacharya, who's on panel, was first author on this review paper. And this review integrates data from various case reports, case series, retrospective reviews, and small prospective studies which have been done till date on anti-cancer drug-induced thyroid dysfunction. So before I move to individual agents, I think it will be a good opportunity to briefly refresh various anti-cancer agents because they have been updated in past few decades. We all know conventional anti-cancer agents, they do work by inhibiting the growth of rapidly dividing cells, including cancer cells. And amongst these agents such as 5-fluorouracil, asparaginase, and mitotane are known to cause alteration in thyroid binding globulin levels. However, they are not known to cause any clinically significant thyroid dysfunction. For example, 5-fluorouracil can increase TBG levels. Mitotane can increase TBG and also increase SHBG and cortisol binding globulin. Mitotane is also known to cause inhibition of TSH secretion from thyroid globes and has been implicated in development of central hypothyroidism. Asparaginase is known to cause decrease in TBG levels and cause decrease in total T4 levels, but with normal free T4 levels. Coming on to targeted anti-cancer therapy, these agents we know work at specific molecular targets, and so henceforth they increase the efficacy of the drug while reducing the off-target adverse effects, as were seen with conventional anti-cancer agents. And these agents have become very popular in the last few decades. Amongst these agents, various tyrosine kinase inhibitors, agents, monoclonal antibodies such as anti-CD52 monoclonal antibody, alemtuzumab, retinoid X receptor agonist bexarotene, iodine-based cancer therapies, and immunotoxins are known to cause thyroid dysfunction. Hormone therapy may be considered as a form of targeted therapy, and in this category, we can see tamoxifen is known to be associated with increased TBG levels. Octreotide, which is known to be associated rarely with hypothyroxanemia and central hypothyroidism. Cancer immunotherapy, again, it can be considered to be a subset of targeted cancer therapy, and it works by increasing the activation of immune system against the cancer cells. And various cancer immunotherapy agents are known to be associated with thyroid dysfunction. This I shall discuss in more details. So moving on to targeted anti-cancer agents and thyroid dysfunction, I'll discuss briefly about each class of agents. So first is, and most important, is tyrosine kinase inhibitors. We know that these agents work by inhibiting phosphorylation of tyrosine residues of various growth factor receptors such as VEGF receptor, PDGFR receptors, RET receptor, BCR-ABL fusion protein, and so they find use in variety of cancers such as CML, GIST, hepatocellular carcinoma, and differentiated thyroid cancers, and also in medullary thyroid cancer. They can induce thyroid dysfunction by two broad mechanisms. The first mechanism is increase in levothyroxine requirement in patients who have already been thyroidectomized, that is in athyrotic patients, and this has been most profoundly seen with imatinib. In fact, it is recommended by some authors that if patient is started on imatinib and has been athyrotic, you can consider doubling the dose of thyroxine at the time of initiation of therapy. And this predominantly occurs by increasing the type 3 dehydrogenase activity. The second mechanism is new onset thyroid dysfunction in patients who were previously euthyroid, and this occurs through inhibition of vascular endothelial growth factor receptor causing ischemic thyroiditis, and this is most commonly seen with sunitinib. However, also been reported by other agents such as sorafenib, dasatinib, and axitinib. As with any other thyroiditis, you can get a phase of transient thyrotoxicosis followed by hypothyroidism. The first one is the onset is quite rapid, occurs within first 2 weeks, and it's been reported in between 20 to 100% patients. While the second one, the frequency varies between 18 to 85%, and onset varies between 4 to 94 weeks. So it's quite variable in onset. The second agent, bexarotene, which is a retinoid X receptor agonist and is used in patients with cutaneous T-cell lymphoma. The major adverse event that can occur with this agent is central hypothyroidism. It is also known to increase thyroid hormone catabolism, but the catabolism that is increased is not through the dehydrogenase route, but is through the increase in glucuronidation and sulfation. While this agent decreases TSH beta gene transcription, it is expected that the effect will be later onset. However, it also has a direct effect on pituitary thyroid troughs, causing a decrease in TSH secretion, and that is why you can get a rapid onset of effect within hours to days, and it's very, very common. It's seen in up to more than 90% of patients. So what bexarotene does out here is, as we know, in pituitary thyroid troughs, you have the TR thyroid receptor and retinoid X receptor heterodimer complex. So bexarotene causes T3 independent activation of this receptor and then downstream effects, which includes inhibition of TSH secretion. Similarly, increased thyroid hormone metabolism through sulfation and glucuronidation route could be a mechanism by which bexarotene could cause increase in thyroid hormone requirements. On the other hand, tyrosine kinase inhibitors, they predominantly work at the level of D3, that is type 3 dehydrogenase. Moving on to third anti-cancer targeted agent, and that is anti-CD52 monoclonal antibody, LM2-zumab. And this is used in patients with B-cell chronic lymphocytic leukemia. Non-oncological indications include multiple sclerosis and graft versus host disease. Now, the mechanism for thyroid dysfunction with this class of agent is quite interesting. This agent induces profound B-cell and T-cell lymphopenia, which is followed by a phase of immune reconstitution. And during this phase of immune reconstitution, you could get a loss of self-tolerance and development of Graves' disease. And this is very similar to the iris or immune reconstitution inflammatory syndrome related Graves' disease that we encounter in patients with HIV infection following introduction of highly active antiretroviral therapy. Now, this side effect of Graves' disease has mainly been described with multiple sclerosis and not so profoundly in oncology patients. And the possible mechanism could be that patients with multiple sclerosis and already existing autoimmune disease are at higher risk for developing other autoimmune disease. The fourth targeted anti-cancer agent is iodine-131 based MIBG therapy or iodine-131 based anti-CD20 therapy, which is used in patients with neuroblastoma, metastatic forms, pheo and paragangliomas, carcinoid tumors, and medullary thyroid cancers who have a pre-therapy scan that is positive. Although this therapy is not FDA approved, we know that lutetium therapy is now FDA approved following the RCTs that have been used. This drug acts by delivery of beta radiation tumor cells, and because some amount of free iodine-131 will be released in this process due to chemical instability, this can go to thyroid cells and can cause thyroid destruction. So the preventive strategy is to use thyroid block, and at our center we use Lugol's iodine, which one drop of which is equivalent to about 6 milligrams of elemental iodine, and this is used at 5 to 6 drops 3 to 5 times per day, beginning 1 day before until 6 days after a therapeutic or even a diagnostic iodine-131 MIBG scan or therapy. And this side effect is actually a late side effect, develops between 1 and 6 years and has been reported variably between 10 to 60% of patients. After targeted cancer therapy related thyroid dysfunction, I'll go in brief about cancer immunotherapy related thyroid dysfunction. So before we go on to cancer immunotherapy related thyroid dysfunction, I'll spend few minutes on what cancer immunotherapy essentially is. If we see, cancer immunotherapy works by increasing activation of your own immune system against target cells or tumor cells. So if you have an antigen presenting cell or a tumor cell, and these are the two T cells. So T cell receptor interacts with MHC or major histocompatibility complex, which expresses the tumor antigen. There are also other signals or co-stimulatory signals, which are CD28, CD80, 86 signal. And this co-stimulatory signal is required for T cell activation. If you have natural immune checkpoint molecules, that is CTLA4, which prevents this co-stimulatory signal delivery and prevents unregulated T cell proliferation. So if you could block this CTLA4 molecule, what will happen is that the two signals will be effectively delivered and there will be good amount of T cell activation, which will work against the tumor cell. However, as a downside, this enhanced immune activation could also result in immune adverse events, including endocrine adverse events. Similarly, PD1 and PDL1 or programmed cell death 1 and programmed cell death ligand 1, these are also immune checkpoint molecules which are expressed by the tumor cells and the T cells themselves, and they inhibit the T cell activation. So if you could block these molecules again by certain monoclonal antibodies, you prevent you cause more amount of T cell activation and you could have immune adverse events. You have cytokines such as interleukin-2, interferon alpha, which can again lead to activation of T cells, B cells, and thus enhance immune activation against tumor cells. And you have agents such as thalidomide and lenalidomide, which are also immunomodulators and enhance T cell proliferation and activation. This is a similar sort of diagram which shows that CTLA4 actually is expressed on T cell and it prevents CD28, CD80, 86 interaction. If you could block this molecule, there is T cell activation and tumor destruction. Similarly, if you block PD1 and PDL1 using monoclonal antibodies, there could be T cell activation and enhanced tumor destruction. So if you see, immune checkpoint inhibitors are molecules which inhibit these checkpoint molecules. So you have anti-CTLA4, which is ipilimumab, anti-PD1, which is nivolumab, and anti-PDL1, which is atezolizumab. So these agents have found use. Initially, they were used in patients with metastatic melanoma. However, in last few years, the indications are expanding, and these are used in patients with renal cell cancer, bladder, prostate cancer, and as well as lung cancer. And these agents, as we have seen, they inhibit immune checkpoint molecules. They cause immune dysregulation, and they can result in immune-related adverse events in various organs, including skin, where they can cause rash and pruritus. In gastrointestinal tract, they can result in colitis and hepatitis. In terms of endocrine adverse events, you can have effect on pituitary and thyroid. In pituitary, you could develop a hypophysitis, which is very peculiar, and I shall discuss this. In terms of thyroid, you can develop primary thyroid dysfunction in form of painless thyroiditis, transient thyrotoxicosis, hypothyroidism, and rarely Graves' disease and euthyroid orbitopathy have also been described. Hypophysitis has been described at an average of 9 to 24 weeks and in 5 to 17% of individuals. As I will discuss, there is a good retrospective review, a large retrospective review of 154 patients where it was found in 11% of patients at a median of 8 weeks. And it's been found that the incidence does not increase much even if you use a combination of CTLA4 and PD-1 inhibitor compared to use of CTLA4 inhibitor alone. Primary thyroid dysfunction has been reported variably at between 1 to 22% at median of 6 to 8 weeks. And the risk is clearly higher with combination therapy, being 22% when combination therapy is used as compared to when CTLA4 inhibitor is used alone. And this has been shown that patients who develop hypophysitis or thyroid dysfunction, they have improved survival. So if we talk about ipilimumab hypophysitis, central hypothyroidism and central hypoadrenalism are the two most common adverse events, as is also seen with traditional lymphocytic hypophysitis. Central hypothyroidism is seen in about, can be seen in up to 100% of patients, and you often get low prolactin and hyponatremia, which can be seen in up to 50%. This is the large retrospective study of 154 patients with metastatic melanoma, and the authors reported hypophysitis in 11% patients. All of these patients had diffuse pituitary enlargement, and as soon as they stopped ipilimumab, within 40 days of ipilimumab discontinuation, you had resolution of pituitary enlargement. Interestingly, pituitary enlargement was reported to be both homogeneous as well as heterogeneous, showing heterogeneous enhancement. And in 8 patients, the enlargement preceded the clinical diagnosis of hypophysitis, and median survival was significantly higher in those patients who developed hypophysitis. This is a picture which shows development in the B panel of both sides. You can see this is the pre-therapy scan, and you can see the development of pituitary enlargement. And in this case, you can see heterogeneous enhancement, which resolves following the discontinuation of the primary agent. Moving on to other immune therapy agents, interferon alpha, which is the use of which is declining in lieu of better cancer immunotherapy agents. And it was mainly used in patients with metastatic melanoma. However, it was also used in non-oncology indications such as hepatitis C. There also, we are seeing better agents that are being introduced. And this agent acts by increasing expression of tumor antigens and MHC1. Also, it has got some direct anti-tumor effects. So in patients who have pre-existing autoimmunity, this agent causes thyroid dysfunction by autoimmune thyroiditis. However, if there is no pre-existing autoimmunity, you can also get a destructive form of thyroiditis. Presence of TPO antibodies that is known to increase the risk of thyroid dysfunction by about 4. And the frequency of this adverse event varies between 2 to 10%. And autoimmunity or thyroid peroxidase antibodies develop in around 20% of patients. Interleukin-2, again, it works by enhancing the activation of different cells of immune system, and that it can cause autoimmune thyroiditis. The frequencies, they vary between 10 to 15%, 10 to 50%. Data are very limited. Thalidomide and lenalidomide, again, these agents are not very commonly used these days. These are used in patients with multiple myeloma. Proteasome inhibitors are more commonly used these days. They also find use in certain types of myelodysplastic syndrome and in patients with ENL in dermatology practice. They cause thyroid dysfunction through the mechanism of immunomodulation and thus causing autoimmune thyroiditis. And also by anti-angiogenic properties, they can cause ischemic thyroiditis. So if we summarize various anti-cancer agents and thyroid dysfunction, you could summarize the mechanisms as follows. You could have autoimmune thyroiditis with cancer immunotherapy agents such as interferon alpha, interleukin-2, immune checkpoint inhibitors, thalidomide and lenalidomide. Ischemic or destructive thyroiditis through tyrosine kinase inhibitors, interferon, which can cause direct thyroid dysfunction, thalidomide, which has got anti-angiogenic effects, and MIBG iodine 131, which can cause radiation thyroiditis. Primary hypothyroidism preceded by a phase of thyrotoxicosis can be seen with all the above agents. Secondary hypothyroidism is mainly a side effect with bexarotene, but also seen with immune checkpoint inhibitors, mainly anti-CTLA4 ipilimumab. It has also been described with mitotane and octreotide to some extent. Graves' disease is a major adverse event with alemtuzumab during the immune reconstitution phase, but rarely described with interferon alpha and immune checkpoint inhibitors. Increased thyroid hormone metabolism is an adverse event that is seen with tyrosine kinase inhibitors through the deiodinase mechanism and with bexarotene through the other pathways such as glucuronidation. TBG alteration, which is not very clinically significant, may be seen with mitotane, 5-fluorouracil, asparaginase, and tamoxifen. The monitoring for thyroid dysfunction is not, it's only that we need to have a close watch for these adverse events. Monitoring is not very difficult. So if you have tyrosine kinase inhibitors and a patient who is athyroidic, you should monitor TSH before the onset of treatment and then every 1 monthly till you get a stable dose. And then you can do a routine sort of monitoring at 2 to 3 months interval. Similarly, in patients who are euthyroid but are at risk for developing ischemic thyroiditis, a TSH before treatment and then every 1 month for next 4 to 6 months, and then you can do every 2 to 3 months monitoring. For central hypothyroidism that can result from bexarotene, it's recommended that you can consider starting thyroxine of 50 micrograms with initiation of bexarotene itself because the adverse event is seen so frequent. And you monitor TSH and free T4 before treatment and every 1 week till you get a stable dose. In patients with prior hypothyroidism, you have to be more vigilant and you have to closely monitor. It's important, and it's been mentioned that you can stop levothyroxine or reduce to pre-treatment dose when bexarotene is stopped because the adverse event is known to be reversible. With alemtuzumab, interleukin-2 thalidomide, you can go with standard TSH before treatment and every 2 to 3 monthly monitoring. Iodine 131 cancer therapy, you should use thyroid block in all patients, and you should go for TSH before treatment and every 6 monthly, and this should be almost lifelong. This is a late adverse event that has been reported as late as up to 6 to 7 years. Interferon alpha, the monitoring will depend on or baseline TPO antibodies. If they are positive, you can monitor every 2 to 3 months, else you could go for a monitoring at every 6 months. With immune checkpoint inhibitors, it is recommended, especially with ipilimumab, you should consider monitoring of TSH and free T4 before treatment and before each cycle, along with ATM. So, baseline MRI pituitary should be considered. Keep a close watch for mass effects such as headache and hyponatremia, and there should be low threshold for hormonal evaluation, anterior pituitary evaluation. Posterior pituitary deficiency, DI, is very, very uncommon in ipilimumab hypophysitis and also for MRI image. Management of thyroid dysfunction, it's not any different from what we do in our routine clinical practice. However, there are a few points of caution. Levothyroxine therapy as per standard recommendation in patients who are developing thyroid dysfunction following iodine 131 MIBG, you can consider treatment even with subclinical hypothyroidism and TSH between 5 and 10 because of theoretical risk of malignancy due to radiation, and you don't want TSH to go up in such patients. For transient thyrotoxicosis, you could use beta blockers, and Graves' disease you could treat as per standard recommendation, but you should remember that you may not be able to use thyroid scan, especially in a patient who has undergone recent iodinated contrast imaging, and this is not a very uncommon scenario in cancer patients. Secondary hypothyroidism, you use levothyroxine therapy as per standard recommendation, maintain free T4 levels in mid-normal and upper normal levels. However, if patient is having hypophysitis and coexistent glucocorticoid deficiency, you should consider 3 to 5 day course of glucocorticoid therapy first, followed by a combination glucocorticoid and thyroxine therapy. Increased thyroid hormone metabolism treatment is to increase thyroxine dose. And TBG alterations, these are usually not clinically significant. These can be followed clinically. So to conclude, as newer drugs are getting available with us, there are off-target adverse effects, including those on thyroid, and we need to be vigilant. There are different mechanisms by which these thyroid effects can occur. At present, there are no known preventive strategy, with the possible exception of thyroid block, where we can use with iodine 131 MIBG therapy. The only thing that we need to remember is that we need to suspect for these, screen them, and treat them. It's been seen that there are improved therapy outcomes for primary disease, and this is very interesting, but the data are mainly derived from retrospective studies, and in future, we need to further explore the bidirectional relationship, how thyroid dysfunction affects cancer and how cancer affects thyroid gland through very well-designed prospective studies. Thank you for the patient listening, and I hand over the dais to Uni sir and Jay.